Okay, hello everyone. I hope you are all doing well. We are glad to be having our 5th session of the Oxygen series in critical care. And I will be sharing with you some of the housekeeping items and the schedule for today. I hope you can all see the screen which shared. Okay, as I mentioned before, today is our 5th session of the Oxygen Therapy and Critical Care, the Care at Tafawa Balewa University Teaching Hospital in Okay, so with us is Dr. Irene Irinosen Akideno from Irua Specialist Teaching Hospital in Nigeria. We will also have Dr. Hassan Maina Ali from Federal Medical Center in Yola, Nigeria. We are also going to have Dr. Musa Kalamu Suleiman from the John F. Kennedy Memorial Medical Center, Monrovia, Liberia. So those are going to be our panelists for today. So some things to remember: our programming is based on the foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for question and answers at the bottom of the screen. Please send all your questions through the chat box and feel free to introduce yourself. Please turn on your video, position your webcam effectively to show your face if you are alone or to capture the whole group. If you have any IT issues, send a message through the chat. And remember that the session is being recorded and your attendance is the consent to be recorded. Mindful of infection prevention and control, and try to limit your numbers of people joining from one gathering place and practice. We have a French interpretation available. You need to have a newest version of Zoom for this to work. And if you can check at the bottom slide of your screen, you may see the interpretation button. So you can click the interpretation button if you need the French, and then you can choose French. So all of you will be able to hear both French and English, but the translation will be louder. But if you don't want to hear the English component, you can choose to mute the English, and then you can hear only the French. So after sharing that with you, Dr. Datti, please welcome to lead on the session. I can share the LRC and you can begin. Welcome.
Thank you very much and welcome everyone. Today we will be doing session number 5, which is critical care outside of the traditional intensive care unit. And it will be a case-based discussion to illustrate this. And our case for today is a 54-year-old male patient with a history of coronary artery disease and type 2 diabetes mellitus, admitted to the inpatient ward 3 days ago with COVID-19. So this is the case we'll be discussing to illustrate this. Now, the practice change objectives we desire at the end of this discussion, we should be able to define critical care continuum. We want to show that critical care is not an isolated thing. Now we need to connect all the trajectory of the patient's illness, whether in the ward or in the ICU and in between. And we will need to understand the SpO2 goals for oxygen therapy. And we should be able to define and utilize the different scoring systems, QSOFA, MUSE, QCSI will tell you what they mean. And then we should be able to outline the life-threatening signs and symptoms indicating time critical care is needed. And we should be able to identify the key personnel that offer time critical care. At the end of it, we should be able to create, or we should take the message that we should create or review the rapid response team policy documents for your institutions. And then we should be able to practice and also be able to simulate scenarios to identify gaps and areas in need of improvement. Okay, so we'd like to start with this, trying to define the critical care. Now, the practice change action item here is to try to define the critical care continuum, not in isolation. So we start with a question here for all of us. You can type in the chat box. Which of the following are considered critical patient care? 1, early recognition, assessment, and decision-making for deteriorating patients. Rapid and timely interventions for patients at risk of clinical decline. Identification of clinical warning signs prior to cardiac or respiratory arrest. Providing expert assistance in response to concerns for a patient's status. And then number 5, all of the above. So you can just type in the number there. We give you 30 seconds. Okay, all of the above, all of the above, excellent. All of the above. All of the above. Excellent responses. Okay, I think let us move on. Let's scroll down. Excellent. Number 5. Okay, so patients whose condition deteriorates acutely that within a short time while hospitalized will often exhibit warning signs. Such warning signs are usually considered abnormal vital signs in the hours before experiencing some form of adverse clinical outcomes. In contrast to standard cardiac arrest or code blue teams, which are summoned only after cardiopulmonary arrest occurs. Rapid response teams are designed to intervene during this critical period using the early warning signs, usually on patients on general medical or surgical wards. This is what we always see. So let's now, how will you define critical care? Where does critical care occur? And how does critical care differ from intensive care? So Dr. Irene, if you can hear us, I can see you're okay today. If you can take us through this section briefly to understand, and when you click, let's see what we have. Thank you.
Thank you, Dr. Datti. Good afternoon and welcome, everyone. For a lot of us, the times that we interchange critical care and intensive care, but with this this echo assist, the idea of critical care goes more of a continuum. Looking at, I'm sure we can always get this article to read. I'm sure the link will be posted in the chat box. But for critical care, it's more like a continuum of patients pre-ICU, within the ICU, and post-intensive care. So how the intensive care is more like within the intensive care unit. For critical care, it starts from patients who are even on the ward. Those who the nurse will come and see, we may not admit them into intensive care. We may have some interventions we can do. So the whole idea is to understand that critical care is a continuum. It's a process, it's not just one aspect. So it starts from the pre-ICU, within the ICU, and when even we discharge a patient out of ICU, and we usually need to go and follow up. So that's the concept of critical care. And like I say, patients who are on the ward, if you look at the pre-ICU as part of the critical care component, these are patients who you feel they're using the warning signs. They're either getting more hypotensive or more tachypnic or dyspneic, or requiring more oxygen support. So of course, there's a call or an invite for either a critical care team or a rapid response team, if hospitals have them, or the staff in ICU to come and evaluate this patient. And usually you could go and see the patient and say, oh, I don't think this patient needs to come to ICU now, but these interventions can be given. Patient is hypoxic. Can we change the oxygen delivery device? Can we resuscitate and see if that would help? So those are the pre-ICU components of critical care. However, in reviewing these patients, the important thing is you let the nursing staff know that you're available, and if patient deteriorates faster, you should be called upon, or there's a chain of communication. If patient deteriorates, this is what should be done. Or if patient deteriorates further, we've come to see already, you don't need to call us, just send the patient, send to inform ICU to receive this patient. Now, there's also when the patient is in ICU, it's a continuum of care, caring for the patient at that point for whatever the issues are, and trying to limit the critical care illness. A lot of patients in ICU are usually recumbent, poor ambulation. They tend to have critical illness, myopathy. They're quite disoriented, especially in the elderly. So the whole idea is, how do you also reduce this component in the ICU? Having relatives come around to talk to them. I know sometimes in a lot of our centers, depends on where you work, we usually do not allow relatives to come in so much, but we have to realize they are quite important in reducing the critical care illness. Even when you discharge them, it helps in their orientation. They're more familiar with these relatives than with us, the healthcare givers. So it's important we allow the relatives participate, communicate with them so they understand how much their input is in the care of the patient. Early ambulation is also important. Now, when patients are fit to be discharged to the ward, critical care still continues. They may have left the ICU, but critical care continues. That means we should be able to have a team to visit this patient. And there's something I say, once you're discharging a patient from ICU in the discharge summary, always indicate that you're open to receive this patient if they deteriorate. So they know that going to the ward does not mean they cannot come back, they can. Now, it's also important that a team visits these patients we've discharged from the ICU to see how well they are coping, to be sure that they are recovering and recuperating very well. They're having good physiotherapy, feeding, they're ambulating, because that will also help to prevent them from coming back and to improve their care. So I'm sure we can go back to read this, but this just shows us how critical care is from pre-ICU, within the ICU, and post-ICU.
Thank you very much, Irene, for that explanation. It will be much clearer as we progress. Let's look at the case we have to begin to illustrate this. Let's look at a case example. Right. So the setting goes like this. You are working in a rural hospital. The nearest hospital with an ICU is 90 miles away by ambulance. But the roads are closed today due to bad weather. So this is the history of the case. This morning on medical ward round, you saw a 54-year-old male patient with a history of coronary artery disease, hypertension, and type 2 diabetes, admitted to the inpatient ward 3 days ago with COVID-19. His chief complaint is shortness of breath. And on rounds in the morning, you notice he was slightly tachypneic, a respiratory rate of 27 breaths per minute, but still speaking in full sentences. He requires oxygen by nasal prongs at 3 liters per minute. He has few crackles on lung examination. His examination is otherwise unremarkable. And here are the vital signs. Respiratory rate 27 breaths per minute, temperature is 37.9 degrees Celsius. He has a heart rate of 95 beats per minute and a blood pressure 107/59 millimeters of mercury. And the saturation on that is 92%. So what is your interpretation of the patient's vital signs and physical exam? Let me call on Dr. Suleiman. Dr. Suleiman, are you with us? Dr. Suleiman? Okay. Dr. Suleiman? Okay. Maybe Irene, because I understand Dr. Salim will be joining us later, he's having a case. So
Okay.
let's just continue. Maybe Suleiman is having some issue.
Okay.
So let's see what's the interpretation of the patient's vital signs and physical exam.
Okay. Should I go ahead?
Yes, Irene.
Okay. So on this table, we have the vital signs, which we should expect in normal adults: temperature of 37, heart rate of 60 to 99, same with the pulse, blood pressure of 120/80, respiration of 12 to 16, oxygen saturation of 95 to 100 in room air, altitude of 7.3 to 7.5. For our index patient, so if we all have this at the back of our mind, so that is it. So our index patient now has a respiratory rate of 27, temperature of 37.9, heart rate of 95, blood pressure 107/59, and SpO2 of 92. So we can see that there are some areas that don't seem to be okay, just using the vital signs. But we're told to interpret it not just with the vital signs, but with the physical examination. So it's quite important that we use that. Now, he's short of breath. Respiratory rate is 27, so he's tachypneic. He's still speaking in full sense, but he requires oxygen by nasal prongs. And at 3 liters, his SpO2 is 92. the lungs aren't so clear because he has crackles. So we do some stuff on physical examination and vital signs. So, so we know these are not normal. He probably will need, do we want people to give some responses or I just continue?
Yeah, that's okay. I think it is clear that we are beginning to see some early warning signs that the vitals are beginning to get abnormal. For example, the respiratory rate is a mild tachypnea now, and the temperature is approaching 38. So I'm sure the patient will be febrile to touch. And then the blood pressure has started also coming down, even though it's still normal, but it is getting abnormal. And then you have saturation coming down. The patient is becoming hypoxic. And you should also remember in the history, this patient has all the risk factors for COVID-19 patients. He's hypertensive, he has coronary artery disease, and he has a type 2 diabetes mellitus. So all these things should be put together to interpret this result and begin to act. So let's scroll down. So now the practice change action item here is that you see the SpO2 read 92%, and then you're given, let's look at the update. Despite the 3 liters per minute of oxygen being delivered via nasal cannula, now we want you to remember the sessions we have on oxygen therapy and the devices we have. You should all try to combine them together in treating this case. Let's not be treating the cases in isolation. We should be bringing what we have learned in other sessions into the case discussions. So 2 hours later, the patient's SpO2 decreases to 86%. When you arrive, he appears to be more tachypnic and is working harder to breathe. He can only speak 2 to 3 words at a time. Remember earlier on, we said he could still complete sentences. You can talk to him. Now he's only able to utter 2 to 3 words at a time. So now the question here is that what is the goal SpO2 in this adult male patient? And then what intervention should be taken for this patient? So we have Dr. Suleiman from Rovia. Now I'm sure you can be able to join us. Can you take us briefly through this one for our participant to understand?
Okay, sir. Can you hear me now? Because I was talking the other time. It's like I was not being heard.
Yeah, maybe you were muted, but it's okay now. Go ahead.
Okay, no, I wasn't using an earpiece then. As the earlier discussion has gone, this is a patient that is deteriorating. Let's go back. Let's go back. Okay, this is a patient that is deteriorating. We've all saw the picture that he presented with and what he's having now. So let's click here and see what we have. Let's click on the, okay. So this is an overview of what is recommended in terms of oxygen therapy based on the oxygen saturation of the patient. As you can see in the box here, there as the saturation from, okay, the range of saturation from 96 to 100, there's a strong recommendation that oxygen should not be given just to take or to increase oxygen saturation above 100. So for this patient, once you are able to achieve a saturation of 100, okay, it's okay. I mean, a saturation of 96. There is there is also a recommendation 2, which is a weak, the evidence there is weak. For this first one, the evidence is a very strong evidence. And of course, we all know our various level of evidences, from systemic reviews to randomized control trials and the rest. What this one is saying is that between 90 to 92, there is a weak recommendation that oxygen may not be started, okay? That oxygen may not be started between 90 and 92, because evidence have shown, we don't have much time. If we have opened up everything there, we'll now realize that, there are some studies that they use to come to these conclusions. While the recommendation 3, which is a very strong evidence based on a strong evidence, is saying that once saturation is 93 and above, there may not be need to give oxygen therapy. This may sound a bit different from what we are used to. However, we are in a COVID era where oxygen has become a very essential commodity, and therefore judicious use of oxygen is being recommended. So these studies have compared mortality and morbidity between patients with these problems whom oxygen was used, and those that were not given oxygen, and they come down with this recommendation. So let's move down to like for the first recommendation, there are some exceptions actually. Okay, so they are saying oxygen once oxygen is 96 and above, don't give oxygen. Okay, I mean, once oxygen saturation is 96 and above, don't give supplemental oxygen. However, exceptions to that are carbon monoxide poisoning, and which we may know the reason, because it may be giving you a falsely high reading. The absorption is almost the same with that of oxyhemoglobin. So patients with carbon monoxide poisoning may have high saturation, which is usually false. Then also patients with cluster headaches, school cell crisis, and patients with pneumothorax. This particular group of patients, even if the saturation is 100%, you should continue supplemental oxygen. And the evidence for this recommendation is a strong one. So most likely a randomized control trial or a systematic review. Okay, let's move down. Okay, so this second recommendation, I've already explained it. However, the study for which this recommendation is based is a weak one. Therefore, if you look down, let's move down, you will see that what is written there is a suggestion. Okay, they said that they are suggesting that oxygen therapy should not be provided. However, I believe for this, as a clinician, you should use your clinical judgment, because a single absolute value of oxygen saturation is not as important as knowing your trend of oxygen saturation. For example, for a patient that was initially having a saturation of 95, 96, and suddenly deteriorating to 92 or less, I think you should commence oxygen before you start looking for the possible cause. Okay, and the last one is saturation of, let's move down, is saturation of 90 above 92, 93% and above. And the recommendation is also that oxygen therapy should not be instituted at this level of oxygen saturation. This is based on the research also conducted, because the evidence there is strong, which shows no difference in terms of mortality and morbidity between patients with acute stroke or MI that are maintaining saturation of 93 and above on room air, and those that are being given oxygen. However, like I've said, your clinical judgment, supersedes. This is just a guideline, and it's more important when you have to, ration your oxygen. All these are being done considering that we are in a pandemic period where, supply of oxygen may not be adequate, so as to be able to, judiciously use the scarce oxygen that we have. Let's go back to the main. Yes.
Okay.
So that's that on.
Thank you very much, Dr. Suleiman, for that explicit explanation. And you remember that at the Learning Resource Center website, you can have all these materials available for you to download and go through them. Now, let's go to the update. Remember, we are monitoring these patients' vitals because we're talking about early warning signs that can help us manage the patient. Here is the update. New vital signs are obtained for the patient. Respiratory rate now has gone up to 32 beats per minute. Temperature has gone slightly up, 39 degrees Celsius, and heart rate has also gone up. And then the blood pressure has gone down, is going lower, and then the saturation, that's SpO2, 86%. Now, we want to look at how we can use the clinical scores, the warning scores, and what we need to learn to change our practice for the good of our patient is how to define and use the QSOFA, that's the quick sequential oxygen failure assessment, MUSE, that's a modified early warning scores, and the QCSI, which stands for quick COVID-19 severity index scores. Now, the question here is, and you can type in the chat box, which of the following are possible differential diagnoses for the signs and symptoms? When you read, you see 1, we have sepsis. 2, you have SIRS, that is systemic inflammatory response syndrome. And then 3, respiratory failure. 4, acute respiratory distress syndrome. Or 5, all of the above. I can see Dr. Salim is with us. If he's with us, they will type into the chat box, and then you can take us through this section, please, within 5 minutes. Thank you.
Thank you.
So type in the chat box, please.
I can see the answers are not forthcoming.
Yeah, we give them like 30 seconds.
Okay. One response, all of the above. That's a good response. Okay. Another response to all of the above. Okay, thank you for the respondents. I think we can go ahead. Yes, the answer is all of the above. So based on the sign and symptoms given above, the differentials for this patient include all of the above. So let's go down. Okay, so now we are going to, the question is, what is Q-SOFA and when should it be used? SOFA stands for Sequential Organ Failure Assessment, and then the Q stands for quick. It's actually a screening tool that you use to identify high-risk patients with suspected infection outside the ICU. And this is the assessment is done based on three clinical parameters, that's signs and signs, which include one is altered mental status, that is the GCS of less than 15, and then the respiratory rate of greater than 22 cycles per minute, and then the systolic blood pressure of less than or equal to 100 millimeter of mercury. So if a patient has two or more of these two signs, then it is referred to as a positive Q-SOFA. And then that indicates a high risk of poor outcome in patients with suspected infection. And this patient we are talking about, they are patients outside the ICU. Okay. So when we should, what is important that we should remember that this is not a diagnostic tool, but rather is a predictor of mortality. It identifies patients outside the ICU with suspected infection that are at high risk of in-hospital mortality. And then with the frequent, and then it should not, it's something that should be done frequently so that to assess the patient and to assess the trajectory of patient disease. So it can help increase suspicion or awareness of a severe infection process and prompt further testing and or closer monitoring. Whereas when the negative Q-SOFA is when the score is less than 2. But this can be repeated if there is a change in patient's clinical status. So it should be done at intervals so that's to be able to track the patient condition while outside the ICU. So this is for Q-SOFA. So then the other early warning is the MUSE, which is modified early warning score, and this one is for deterioration. It determines the degree of illness of a patient, and patients with low MUSE can continue receiving their usual care, and while patients with high MUSE should be watched more attentively and considered for transfer to a higher care unit such as an ICU, because we said that the critical care should be a continuum, pre-ICU, ICU. And the reason pre-ICU, the rapid response team is there to assess the patients. Whenever there is a need for escalation of care, then such a patient will be moved to the ICU. And this is very important, especially in our own settings, where we have limited ICU beds. So it's not every patient that will require ICU admission that will certainly be admitted into the ICU. But then what can we do? If the patient needs the ICU and we don't have the available bed space, then there are some interventions that we can do in the ward and to make the life of the patient better. So the modified early warning scores is based on 3 signs, with the systolic blood pressure, the heart rate, the respiratory rate, the temperature, and then the AFU score. The AFU stands for alert, or when the patient is alert, he got a better score. And then the V stands for or with the patient responds to voice, or the P when he reacts to pain, and then the U is when the patient is unconscious. So based on this, there are scores assigned to every sign that is being gotten from that patient, and then at the end of the day, the scores are put together. So a patient with a lower score should receive his usual care and then an observation, whereas patients with a higher score need frequent monitoring and then possible escalation of care. Okay, so that is the mu score. So whenever you get this score can be used by any healthcare worker, and proper training in how to use it and interpret the results. It is meant to be used on a regular basis rather than once on admission. Then the next score that was recently introduced following the COVID-19 pandemic is the QCI score, which stands for quick COVID score. So the quick COVID severity index, it actually predicts a 24-hour risk of critical respiratory illness in patients admitted with COVID-19. So when to use it is you consider applying the QCI to risk stratify COVID-19 patients who have been admitted to the hospital. So, and this is assessed based on three parameters. One is the respiratory rate in beats per minute, breaths per minute. That is when you have respiratory rates of less than 22 cycles per minute. It's actually a range that is scored 0, and then 23 to 28 is scored 1 plus 1, then greater than 28 plus 2. So the next parameter is the pulse oximetry. And the pulse oximetry, what you do, the pulse oximetry is the lowest value that is recorded during the first 24 hours of the patient encounter. So you look at the first lowest value that is recorded within the 24 hours, and then there is a category, whether if it is less than 92 or between 89 to 92 or less than 88, depending on the value that is a score for that. And then the last parameter is the oxygen flow rate in liters per minute. So you look at the oxygen flow rate, and then based on the flow rate also there is a score for that. And then the one good thing about this course, there are apps and then softwares that you can just input your findings, and then the calculation will be done to you, and then the result displayed, and then based on that you can act. Okay, thank you. Dr. Datti? Hello?
Dr. Datti, I think you are muted.
Yes.
So I don't know, Dr. Irene, can you take over before he comes back?
Okay. I guess so.
And yeah, with the anchoring.
Okay.
Yeah.
So the next segment is to define rapid response systems. Our change is our change action item here is to outline the life-threatening signs and symptoms indicating patients need time-critical care. So we're just coming from what do we see to know that this patient needs a response. So we have an update on this patient. So he's suddenly lost consciousness. So he was stopped making sentences, then words. Now he's lost consciousness. We've gotten some new vital signs. Let's see. His respiratory rate is now 40. Temperature is 39, very febrile. His heart rate is hitting the roof, 147. Blood pressure has dropped, 63/25, and his SATs are now 66%. I think Dr.
Sorry, I'm back.
Okay. Okay. Welcome back. I just read through the vital signs.
Yeah. Sorry, I had a glitch here.
Sorry.
So I'm using my phone now, which is okay. All right. Thank you, Dr. Salim, for that beautiful explanation through the warning scores that we can use. I want to add here that the participants should know that in low resource settings, which we all find ourselves, we don't need sophisticated equipment. All that is required of you is to use these vital signs, which our nurses are everywhere, at every unit and every corner recording them. Please make use of these tools and the information being recorded all the time. And you can see the early warning signs, and you have the scores increasing, then you are being forewarned early to intervene. Now, the next session, which Irene will take us through, we'll try to see, now we know we have this, we've been doing that. What is missing now, or what this session is trying to tell us is that we can actually connect all this wherever the patient is being treated, whether in the ward, whether is in the ICU or is leaving the ICU, then you can actually connect. Because the first reference article was trying, in summary, that you need to detect the patient is deteriorating, and you need to mobilize early. And then you need to have good communication. So in doing that, then we need to develop systems. And this system is rapid response system. So Dr. Irene, maybe you can take us through this session to understand what is this rapid response system and what are the components using the case-based study. Thank you.
Thank you, Dr. Datti. So we're going to talk about rapid response systems, and it's a system that outlines, that kind of manages patients' need for time-critical care. It has actually helped a lot in reducing cardiac arrests, mortalities, ICU admission. Like the name goes, rapid response is like rapid response squad. These are not necessarily the cardiac arrest teams. What this system entails is it has a team and a means of communication, Dr. Datti says, where, like we say, it starts from before the ICU. Having this patient, this case study now, the nurses on the ward would have noticed patient is deteriorating and they need, something has to be done. Who do they call? Which team can they call? Not necessarily the primary caregiver that will respond, because we know with this patient, there's an imminent arrest coming up. So the nurse notices this and says, who do I call? This is where the rapid response team comes in. They come in and address the issues. Now from here, they say, what vital signs do you see that require intervention? Just because of time, but I'm sure a lot of us we agree that they all need. He's pyrexic, his heart rate is high, he's tachycardic, hypotensive, hypoxic. So, you know, if you put him in the early warning score, he's very, very high. If we input all this information into the early warning score, he's very, very high, and he needs intervention to be done. So you see, these are the triggers that would activate that response system in places where they have. In places where they don't have, usually they would send out a consult or send out a call to either the anesthesia team or the ICU team. Because looking at this, heart rate above 140, his is 147. Respiratory rate above 28, his is 40. Blood pressure greater than 180 or less than 90, his is less than 90. SpO2 less than 90, we're having 66. He's lost consciousness, so there's a change in mental status. We haven't gotten to urine output, but of course, we already have a lot there. And I am sure the nurses on that ward are significantly concerned. There was no history of chest pain, but if he's lost consciousness, probabilities that his GCS has dropped and his airway may be quite unstable. We do not know if he's had a seizure, but of course, he's very pyrexic at that point in time. So with all of this, the rapid response team has to come and see and intervene. And there are times that their intervention can prevent the patient moving on to the ICU, or will help to stop an arrest, an imminent arrest happening, and admit this patient into the ICU for continued intensive care. Now, there are different, if we scroll down, now different countries have different names they call these rapid response teams, and they are made differently. But at the end of the day, they all work with these certain triggers, which is relatively universal, and it means we can extrapolate it to our own environment. And they're called different names. Sometimes rapid response team, not necessarily a crash team, but that's the whole idea of that rapid response. Is we have those triggers which the nursing care has seen, and they come. Another thing with these rapid response teams is that they also have opportunities for simulations, because it is important there's communication between the ward staff and the rapid response team, the rapid response team and the ICU team. So scenarios and simulations, so that when these things happen in real time, delays are not made. Information is passed as it should be. There's a closed loop. There's a closed loop of communication. Communication is spelled in black and white, no ambiguity. If patient mental status drops, contact us. If heart rate drops below this, we've seen those triggers, they are straightforward, so it's very objective and a few subjective inputs. Now, like I said, these rapid response teams have come in the continuum of critical care. They've been found to reduce non-ICU cardiac arrest, reduce post-op emergency ICU transfer, reduce arrest even before ICU. So they are very, very important, and we're hoping moving forward that they would be able to have this. Now, would you say, do you need all the triggers or one? Usually, if you have even one trigger and you put it in your MUSE score, it depends on how high it is. The thing is, you have to let the nurses on the ward know which is what the early warning score is, because in some hospitals, they have that at their vital signs and say, when it is amber, do this. When it's red, call the doctor or call the rapid response team. So if you have one or two, based on your score, then you need this team to come in and see what is being done. Remember, the whole idea is that is a warning score. If we do not do anything, those vital signs will not change automatically. Patients will continue to deteriorate, as we have seen this patient. This patient is deteriorating gradually. So it is important that we pick them early, we respond early. And when we do that, we ultimately reduce arrest and improve survival of this patient. Is there anything else to click? Okay. So I'm sure if we go to the Learning Resource Center, we'll get a lot more on rapid response teams. There's a lot of information there. The next question is, which of the following may be needed for this patient? So if we can just answer that in the chat box to be sure that we looked at this patient in totality and had a plan if we were the members of that rapid response team. I hope everyone can still hear me.
Yes, we can hear you.
Okay. So if we can, we've seen how he has deteriorated. So which of the following interventions may be needed for this patient? Higher level of care, increased oxygen therapy, more frequent monitoring, ongoing resuscitation, airway management, all of the above. So if you can answer from 1 to 6, thank you. Because most of us who are here on this discussion are probably the people who will be called, who will be part of this rapid response team, or we would be on the wards and we have this patient and we've seen that this patient is deteriorating. Thank you very much. Very correct answers. So of course, he will need a higher level of care. He's deteriorating quite. All his vitals are off the hook. saturation, he will need increased oxygen therapy. Like Dr. Datti said right from our first session, do we need to change devices? He's been on nasal prongs. Have we moved him up, to face mask, to non-rebreather, to high flow nasal oxygen and intubation if he has lost consciousness? So we must still follow that algorithm. More frequent monitoring, of course, because he's doing by the second. And for whatever intervention we give, we need to be sure, is this improving or we need to change? Ongoing resuscitation, that's true. Airway management. So all of the above. Thank you very much for your responses. So now I think this is a nice one for us to answer. This is a poll. Does your facility have a rapid response system for inpatients? 1 yes, 2 no. Are we going to have it as a poll or they just fill it in the chat box? Okay. So we have 2 no's. Does your facility have a rapid response system for inpatients? No. Okay. I'm hoping to find a yes. Otherwise, we have to have some action and to change our practice. Thank you. Most of our participants have said no. Their host facilities do not have a rapid response system. So that means we have to do something moving forward to improve our level of care, to improve patient survival. Can we scroll down? I hope Dr. Datti is still with us.
Yeah, I'm with you.
Okay. So the last bit, I guess we'll come back to this facility having a rapid response system and how we can do something about it. The next one is, who can activate a rapid response team and for what triggers? So we all have an idea of what this rapid response team is all about. And like we say, it's made up of who can activate it. Now, usually the patients are on the ward. So the nursing staff who is on the ward usually are the ones, because they tend to be the ones who are monitoring the patients by the patient's bedside. They notice what is going on. The doctors who are on the ward may not necessarily be at that patient's bedside at that point in time, but they also can. Relatives also have been found to be able to, should be able to give, to call out the rapid response team or to activate it, because the relative might, especially in some of our facilities where we have relatives by the bedside of the patient because there's a paucity of nursing staff. Relative is there and notices, oh, my dad who was talking now has just stopped talking, and or maybe just had a seizure, complaining of chest pain all of a sudden, his breathing has changed, they notice, so they can activate it also. So there's really no hard and fast rule. I know sometimes you wonder, oh, are relatives supposed to do that? But the whole idea we should look at is patient care and patient survival. So anyone can, but of course, usually the nurses, the primary care physicians, it could even be the physiotherapists while they are doing some physiotherapy on the patient and realize that, oh, this patient who was talking just stopped talking and all that. They are the ones usually who are in that close contact with the patient also, apart from the nurses and the physicians. And we've already talked about the triggers. Now, this just shows like a study on one, the position of the person activity. Like I said, the nurses were the highest, non-medical staff, family members, the cleaners, then the reasons were topmost were the vital signs criteria, using those early warning scores, so they were able to signpost and the nurses knew exactly what to do. Then, of course, the third one was staff worried about patients' mentation or not looking right. I think sometimes we tend to underestimate that, but I think the clinical judgment of the staff, without the nursing staff, especially about a patient, is a very, very strong pointer that this patient will probably need a higher level of care or will need a rapid response team. So it is important we do not gloss over that, apart from looking at the vital signs and the early warning scores. So there are so many, like I said, the pulse rates, blood pressure, heart rate, seizure activity, unresponsiveness, hypoglycemia, chest pain, patient may have had a fall, altered mentation from unconsciousness to dizziness, hypothermia, focal neurological deficits, all of a sudden the patient can't talk or one side of face is droopy. And the diagnosis that immediately led to that, probably patient may have had a seizure, patient may be treated for sepsis, hemorrhage, hypoglycemia. There's a lot to do. Of course, you would run investigations also while trying to find out why you're having this drop in vital signs. Thank you.
Thank you very much, Irene. At this juncture, I want to make few comments so that we don't miss out on all the beautiful explanation you've given with the resources we have at the LRC. This is the reason why ECHO and Assist International put this together to bring hospitals, whatever level, whether primary level, secondary level, tertiary level, and then whether you are in high income countries or low or middle income country, we can actually put things together and try to improve the patient care. Now, the most interesting part of this is that the answers that whether we have rapid response team, I don't have in my center, and you can see the answer is almost 100%. Now, it means all of us should go back as soon as practicable and as soon as possible to try to form the team. Now, from my understanding, is that we should form the team. That's the first step. And the team, you don't have to have, you look at what is the level of your hospital, secondary level, tertiary, or primary, or whatever. And then you look at the type of personnel you have, and then you form the team. For example, in my center, I've been the tertiary center. Of course, the ICU team on call, which most of the time they are anesthetists because of airway management and so on. We have a HDU, we have an ICU. So where these patients come from, they are on the ward. So we need to now involve somebody, a nurse, one or two of them every day on the ward as part of the team. And number two, so we have what to take. So it doesn't matter your level. You look at your staffing and form the team, no matter how simple. Now, what connects the members of this team will be communication. We are happy today now, as we are speaking now, as we are discussing this case now, we are looking at ourselves live. So communication is no longer a problem. What will be the problem is probably the resources to get data, to have this. But the communication, simple call. So you need to put this team together. You have the WhatsApp group and so on. You can always communicate on the patient on the ward. That this is what you are, and you quickly look at these warning scores and take a decision. Now, what about the equipment that we need? The equipment that we need to have all this information, very, very important information, they are not expensive. Well, no matter the level of care you have a blood pressure apparatus to get the non-invasive blood pressure. You have the pulse oximeters, that whether you have electricity or not, you can use dry cell battery. You have the thermometer, no matter how simple it is. You have in a center where you have multi-parameter monitor, you put all this together for you. So what is required now is the trend as frequently as possible, and then the recording. That is important. What about the facility? The facility, whether you have an intensive care unit or a HDU, then you should have, wherever you are, if you have ICU, fine and good. Then your patient, you begin to prepare a patient to move to the ICU so that you can reverse this trend and not to wait until it is late and then there is little or nothing you can do to reverse the trend in the ICU. Then, but if you don't have ICU, then you should identify how far a facility that has high ICU to consider transfer this patient to that facility so that you can escalate the care based on all these costs. And then you look whether you have, that means you need to have ambulances and so on. So we can do it. So this is a practice change. We must now try to quickly form these teams wherever we are. Now, let's move on. So you can see now what we say, the practice change action, that is what I just explained. Identify the key personnel that can offer time critical care. So, and then what providers should, yes, what providers should respond to this patient's deterioration? So you need to know that. And Dr. Suleiman,
Show you
yes. Dr. Suleiman? Okay. What about Dr. Salim? Dr. Salim? Okay, so let's move on. None of them is available at the moment. So we should know what providers should respond to this patient's deterioration. Looking at the all those vitals, the information we have, you can see you need virtually everybody. You need a respiratory physician, you need the anesthetist, intensivist, because this patient has lost consciousness, so you need to protect the airway, the GCS will be low. You need cardiologists because you need to improve on the blood pressure, which is going down. And nephrologists, you need to know the patient is not making urine adequately. Let's move on. So here, who are the stakeholders needed to implement rapid response system? So let's click and see what we have. Now, on the Learning Resource Center, you'll find this very useful. Like Irene tried to explain, you have modules. It doesn't matter what you call it. What matters is the components, what you have to utilize it effectively. And you can have these contents in this material to guide you. Don't try to put in what you don't have. And you can always improve it when you have those equipment and all those personnel. And you have the link to this material. Okay. Let's go back to the main. Okay, so let's move on. And then what documentation should occur during a rapid response team? Now, there's also a guide here. You can have this kind of form with this information. Now you are free to modify it to suit your setting. What is required is what information you can get from your staffing to get these signs, ascribe the scores and so on, and you fill it, because you need to have a documentation so that you can evaluate your outcome at the end, periodically. Let's move on. Let's scroll down, please. So all this form you can modify, like I said, is very robust. You can make it very simple, remove the information that is not required, but you can always bring the information back based on what you have. Let's scroll down to see if we have some update. Now, you have to now look at implementation of the rapid response team. Now, in implementing it, you look at this acronym, SEDA, S-E-D-A principles. You look at the situation, you look at your setting. What do you have in terms of equipment and personnel? You know, So, and then, your setting, and then that defines the level of care your facility falls into. Then you need to evaluate constantly what you are getting out of the system. And then you need to now take decision, and then you need to act. So when you have the team to implement it, you need to look at the situation based on what the scores are, and then you evaluate, do you need to escalate care? Do we have what to do here? For example, on the ward, this patient that has lost consciousness, is difficult to manage the airway there. So you need to take a decision that this patient must be moved to an intensive care unit so that you can protect the airway, and then you can also escalate the oxygen therapy, and then you have now more monitoring of the parameters that is needed. So you take a decision. And then, of course, the action you need to now implement all those things that you have. Where you don't have ICU, then you need to prepare your ambulance. And then with competent staff that know how to transfer the critically ill patient to the higher center for escalation of care. Let's scroll down, please. Okay, so in the practice change objectives, what is desired here in the situation, what we need to be mindful of is the rapid responses may improve patient outcomes. This we should take home with this. And then rapid response system may identify warning signs before a respiratory or cardiac arrest. This is very important. And is important in our settings where we don't have enough. Then rapid response systems provide time critical care to unstable patients. Don't leave that gap and say, oh, ICU. Now what happens before you take the patient to the ICU? That could be the golden hour. This is the golden opportunity to reverse the trend. So, and that is why we need to have the system and also the team. So in evaluation, you need to create or review the RRT policy document for your institution. If you have, if you don't have, you form one, a simple one, and improve periodically. Then you need to identify the key stakeholders, that is patients, which is central. You have carry along your nurses. They keep this record beautifully and it's always available for us to use. Then the physicians, like Irene mentioned, at some point, you need to also take into consideration what the families are able to observe, the pharmacists, and then respiratory therapists. And then you need to also carry along the other health workers. They are very, very important. You should identify the barriers to, what you need to do, in your system, and try to remove them. Then decision is very important. You have to consider forming the RRT committee, which you can review. You can always evaluate the outcome of what you are doing, periodically. Then ensure key stakeholder perspectives are represented. Everybody is important. Then you should establish a timeline within which to institute or make needed changes. Identify solutions to barriers, always. Then in acting, you need to adapt existing protocols to the institutional resources available. Don't try to implement things. You need the resources, you don't have the resources. Wait until you have those ones, no matter how little you have. But when you are organized, you'll be able to get the best outcome. Can we scroll up a bit? Sorry, the other way around, sorry. Okay. All right, so implementation next steps. You need to look at how you create rapid response policy document for your institution. So everything should be documented. You should define the rapid response team. Who are the members of this team? define the purpose of the policy, define who can activate the RRT. You must have a leader, and then create the alert criteria, triggers, or parameters. You should agree what parameters should we be able to say, okay, this patient should move from point A to point B, or from this facility to another facility. And you should define the procedure for activating the RRT. Who calls, who do they call, who responds, who are the members of the RRT, what expertise do they bring? And you should also define roles of each of the RRT team members, what roles are needed and who will perform which tasks. So, okay, so let's scroll up, let's see. Okay, so these are just to guide you. Like we said, try to modify it to suit your setting. Okay, so the key learning points here is that critical care is a continuum. What we are doing now, excuse me, we have isolated ICU. Like in my hospital, many people don't even know what we do in the ICU unless they have a patient at some point. So the idea is to link the point of care of this patient with all the units in the hospital. It's a continuum. And you can provide critical care outside of the ICU before getting to that unit where you will get that care. Then oxygen should be provided until the SpO2 reaches 96%, but not above. And then we should use inpatients outside of an ICU. You should use the Care-Sess and then indicates further investigation and closer monitoring of patients with suspected infection, the Care-Sess. Then patients with a high modified early warning score should be considered for transfer to a higher level of care. Whether you have ICU, if you don't have ICU, then you should know where to transfer the patient. At this point, I want to apologize to Dr. Hassan Alimena. I've been searching for you. I didn't see somehow. You should have been contributing to this discussion. I thought you were busy. I'm so sorry, please. I'll give you a chance to wrap up things. Then you need to use, when you have suspected COVID-19 patients, you need to also include the QCSI that predicts a 24-hour risk of critical respiratory illness in patients with COVID-19. Then the rapid response team bring time, critical care, and expertise to patients who are unstable. And then activators of the RRT can be anyone, including registered nurses. Please, let us remember this. Could be doctors, physicians, patients, and family members. And respondents to calls for RRT should offer expertise and they include pharmacists, phlebotomists, respiratory therapists, transporters, and so on. The rapid response team, different from the rapid response team, requires the support of administrators and quality improvement personnel. So thorough documentation is needed, and I will remind you, you need to, the team, when it is formed, you should be practicing, you should be simulating scenarios so that when you are called, your response will be positive and will improve patients' care. Dr. Hassan, please, I'm sorry, I have been trying to get you to that. I didn't know you were around. Can you wrap up what you have just discussed briefly?
Okay, good evening, sir. Good evening, all.
Thank you.
Almost everything has been said, but the rapid response team is, from the discussion, is a very important team. It is part of the rapid response system. And we have 4 components: the administrators, the activators, the responders, and the quality improvement team. The administrators are the ones that will set up the team and would continue maintaining the team, while the activators are those people that would activate the code for the responders to come. And then the responders are those people you just mentioned. The activators can be anybody. It can be the patient, can be the patient relative, can be any member of staff in the hospital. It doesn't have to be a clinical staff. Then the quality improvement team are those people that would ensure that the team is moving smoothly, and if there is any change or any observation, they make those observations and try to make corrections. It's like an audit team. So the rapid response team is a very important team. It is different from the team for the code blue, which is called for cardiac arrest. The basic difference is that the rapid response team are not as agile, they do not come that fast like those for cardiac arrest. The cardiac arrest team, the code blue, are the ones that immediately the signal is signaled, they come at a very fast pace. And then it doesn't have to be, that is why it is called a rapid response team instead of an emergency medical system, because it doesn't have to be doctors. It can be any, like you mentioned, doctors, nurses, physiotherapists, pulmonary therapists, all those people can be part of the rapid response team. By and large, I think that is just a summary of what I have to say. Thank you very much, sir.
Thank you very much, Dr. Hassan. And at this point, I want to thank the co-panelists for the explanation and the discussion on this case that has been put together by Assist International and also the Project ECHO, which has all made this possible. I want to thank those who have participated, and I urge them to try to practice this. It is simple because you don't have to acquire more equipment to begin, to form a rapid response system. You can start anywhere at whatever level. And remember that the rapid response system and rapid response team, when you implement it, it will link everybody together and the patient care, that the care of the patient it will link the point of care wherever the patient finds his or herself in the hospital. The care will continue, whether in the ICU or outside of the ICU. Thank you very much. Over to you, Kevin.
Thank you very much, Dr. Datti, and all the panelists. We really appreciate. I'm sure myself and other participants have gained a lot from this session. Now, before we close the session, I would like us to take a brief moment, like a few minutes, for answering the poll. This poll is just to get a feedback on the interpretation. As you know, we had a French interpretation today. So I'm going to be sharing the poll with you, and please just cooperate with us and answer towards this poll. I think you can all see the poll that is launched. So we will take 1 minute to give the participant time to respond, and then we will close the session. Okay, thank you. I will now close the poll. Okay, so that is the end of our session for today. I'm just going to share a few items to close the session. So you can visit the Learning Resource Center LRC for the presentation, slides, and recording. The site also includes many additional resources, quizzes, cases, exercises, and videos. We have shared the link to the chat, and we're also going to share the link to the LRC in the WhatsApp group as well, so you can have an access there. So also the link to the recording of the session will be shared after this session by email. So thank you for answering the Zoom poll. You can join the WhatsApp group by scanning this QR code here, or you can message assist at the number that is written there. So thank you for joining us. Our next session, session 6, is going to be on the 24th of June, 2021. And we are going to be discussing on basic ICU care consideration. So if you have any questions, you can email us at echo@assistinternational.org. So thank you all for joining. Thanks to the panelists, and see you next month.